Right. Thanks very much, Glenn, for asking me to speak tonight. It's a great pleasure to be here. The title of this seminar is To Operate or Not, and the decision-making is a clinical process. I want to explore the thought processes about what actually happens when a clinician is deciding what to do. What is going on in the experienced clinician's mind, and how does it all work? Some of the ways to attempt to answer this is to use an analogy about clinical thinking. One of these analogies is the POSSUM score. It was first developed by Copeland in Liverpool in the UK and first published in the BMJ in 1991. It is a physiological and operative score, and it enumerates mortality and morbidity. So the P stands for physiology, the O stands for operative. It uses physiological variables and operative variables and subjects these to a mathematical formula that we'll have up in a minute. I really tried to stay away from mathematics and try to stay away from statistics, but I think the slide that we'll show a bit later actually brings it all together. Surgeons, statistics and mathematics, it's a very bad combination. Anyway, it's an analogy of what an experienced clinician is actually thinking about, probably without knowing it. We've been doing it most of our lives, probably, without actually realising what we're doing. What we're actually doing is giving individual pieces of clinical information a weighting of significance or importance when compared with other pieces of clinical information. In the POSSUM score, one piece of information can have up to 8 times more significance than other pieces of information. The POSSUM allows for the use of 12 physiological parameters and 6 operative severity factors. This is the physiology score, and that is what a normal person would have, who's physiologically quite well. The operative parameters are on the right. The downside of the POSSUM score, if we look at mortality based on the physiological parameters, like a 20-year-old male fit having an inguinal hernia repair, because of the problems of the mathematics to do with what one of our colleagues will talk about later, it's linear regression analysis. But the problem with it is that the closer you get to 1 or 0, the less accurate it becomes. So if you have all these normal parameters, you have a mortality rate of 1.06%. That's the part of the problem with the system. As it happens, the increasingly sick you become, the physiology score gets more and more close to predicting mortality. So in the cases where you really need it, it actually does come to the party. Now, could I get this next slide? You have to fiddle with it. So the physiological score is to be worked out, how it all works. It's worked out when the patient is ready for theatre. In other words, they've been resuscitated to a maximum degree and they're ready to have a decision about operation or not. That's what this seminar is all about. So the physiological score is worked out at that point. And you can see at the top that each of the numbers, 1, 2, 4 and 8, that's the weighting I'm talking about. That's the clinical weighting that we take into our own minds when we start making these decisions. The cardiac signs are there. The chest radiograph showing cardiomegaly has a factor of 8-fold. The respiratory history is explained. Again, the chest radiograph, fibrosis or consolidation, has 8 points to its name. And the blood pressure is self-explanatory. This actually did, how does that work? The physiological score continues. Pulse, Glasgow Coma score. I was talking to one of the neurosurgeons, in fact Glenn, earlier on. The The Glasgow Coma Score has great relevance, of course, in neurosurgery, and I think a group in Perth are working on it at the moment and making a modification of the POSSUM score, like many people are doing for colorectal, for general surgery, for various other categories of surgery. All of these numbers are really quite clearly, easily obtained pre-operatively, so the registrars and everybody else have got them right on hand. They're actually very easily obtained. So the physiological score is calculated when they're ready for a final decision about to operate or not to operate. It can be used as a predictor. That's the physiology score of mortality of anaesthesia and surgery. As I said, one of the faults of the score is it overcalls mortality in the fit patient. It now can be readily worked out using computer systems at the bedside. Copeland, the author of the system, feels it should not be used as a substitute for clinical decision making. I submit, however, that the POSSUM, among other systems, is actually one explanation of how our clinical decision making works in the first place. It's a numerical way of expressing what we sometimes can't express ourselves in words. The operative score looks at the operative parameters as shown and is calculated about 6 weeks later, post-operatively, usually in the clinic. Again, you'll notice that the numbers go from weight 1 through to a factor of 8. The type of surgery, moderate, is regarded as an appendicectomy, cholecystectomy, other uncomplicated laparotomy. The major is regarded as a laparotomy at which something is done, like a bowel resection or cholecystectomy, exploration of common bile duct. A moderate degree of surgery is probably the majority certainly of emergency surgery. The major plus, which gets a factor of 8-fold significance, is an abdominoperineal resection, a liver resection, a pancreatic resection, or major vascular procedures such as a AAA repair in the expanding setting. As I said, the operative score can really only be sorted out post-operatively. Blood loss you've seen. Again, if there's free bowel content, pus or blood in the abdomen, that has an 8-fold weighting. The presence of malignancy, again, you might not know that until some days post-operatively, so you can't really, in many ways, finish this scale until days have passed sometimes. The mode of surgery, again, is very important. The emergency, less than 2 hours, I think speaks for itself. So typically the score, once it's all obtained, is calculated when the patient comes back to clinic about 4 to 6 weeks later. The other time at which the score is done, obviously there's a mortality rate which is done at the time of the mortality. Putting the POSSUM score completely together at 6 weeks can be used as an audit tool. It was developed as an audit tool in the first place. As it happens, the physiological part of it is a very reasonable predictor of mortality and morbidity in its own right, but it wasn't developed as a predictor of survival and so on. It was, in fact, developed as an audit tool. It can be used as an audit tool to fairly look at the performance of a surgical unit and compare various units. It can be used to look at individual surgeons. It can be used to look at one surgeon's performance, say 5 years later, as the career progresses. So really, its real use is as an audit tool, and that's how it was published. So as a secondary measure, however, it can be used as a predictor. The group in Portsmouth in England evaluated Copeland's POSSUM score in their unit about 5 years after the initial publication of the score in 1991. and this was published in the BGS in 1996. They found that the original POSSUM score over-predicted mortality, performing worst in the low-risk patients, as we've said. It's important to stress in the Portsmouth study that they only looked at mortality. They didn't look at morbidity. They used it as the physiological score only. They didn't really see it as an audit tool. Because, however, of the problems of overcalling morbidity in a well patient, the Portsmouth group modified the statistics and went from the top formula, which is the Liverpool formula, to the P-POSSUM's formula, which is the one below, where R is the predicted risk of mortality. It's the P-POSSUM score. You'll find about it in the literature. I couldn't figure out what the P stood for. In fact, it stands for Portsmouth. The physiological and operative severity score are obtained using a logistical regression analysis, a mathematical technique normally done by computers. That's what this is. Certainly not at the bedside in 1991, but now can be used using a handheld device, as increasingly popular as advances in computing continue to happen. In summary, I've tried to shed some light on the mechanics of clinical decision making using the P-POSSUM score mathematics as an illustration of how experienced clinicians' minds might work as it ponders the question to operate or not to operate. Thank you.